Good afternoon, everybody. Happy Friday, and a special thank you to our guest presenter today, Dr. Ronald Joe, who will be joining us on this webinar to talk about naloxone prescribing for physicians, what you need to know. A little bit about Dr. Joe. He is the medical manager of the Inner City Addiction Program at Vancouver Coastal Health, and he has been practicing addiction medicine for about 20 years now. So obviously has lots of information and advice and wisdom to share with us today. So welcome, Dr. Joe. A couple things before we do start is to let participants know that we are taping this webinar and it will be available online a day or two after we've completed today. So it'll be available on www.preventingcrime.ca, and you can find the rest of the webinars there as well. Participants are muted, and if you do have a question, you can type it into the question area to the right of your screen, and we'll be able to see that and ask those on your behalf to Dr. Joe. Or alternatively, if you click on the attendee list, you'll see your name. If you want to raise your hand, if you have a question, we'll be able to call upon you and unmute your mic, and you'll be able to speak as well. So I think that's it for now, and just I'll hand it over to Dr. Joe. And again, thank you for joining us this afternoon.
Thank you very much. Hi, my name is Ron Joe, as I've been introduced. I'm going to bring on the PowerPoint here. So as mentioned, I'm a physician and have been practicing for over 20 years in primary care and addiction work. I work full-time for Vancouver Coastal Health as the medical manager for Inner City Addiction. Firstly, I'd like to thank the Waterloo Region Crime Prevention Council, the Eyes Wide Open series, Michael Parkinson, the sponsors, and the advocacy and the hard work from the organizers and the people on the ground to make this webinar possible. I have no disclosures or conflict of interest. So introduction, my talk is on the provision and the use of naloxone in the intervention of opioid overdoses. I'd like to emphasize that this is only part of a comprehensive initiative to reduce opioid-related morbidity and mortality. It would be naive to think that providing a prescription for naloxone would work in isolation from a broader scope sorry for the glitch there, I had a pop-up. From the broader scope of education, prevention, enforcement, addiction treatment, and other harm reduction initiatives. So the objectives of this talk: first, I will discuss some of the basic principles of pharmacology to inform ourselves of the current understanding of mechanisms of naloxone. Then I will discuss some aspects of the current regulations in Canada which have relevance to prescribing of naloxone and how they fit in with our emerging public health take-home initiatives. Thirdly, I will then discuss some aspects of the effectiveness of naloxone, and then finally I will discuss the logistics of prescribing naloxone and the assessment and opportunities to engage your client group and the provision of emergency naloxone and drug treatment. What is naloxone? Naloxone was discovered in the 1960s, so it is not new. Naloxone has a chemical structure similar to that of natural opioids. It is not considered a habit-forming drug in contrast to opioids. Also, it is on the World Health Organization model list of essential medications for its life-saving ability to reverse opioid overdose. For comparison, the leftmost molecule here represents naloxone compared to that of codeine and morphine on the right-hand side. The carbon-based ring structure is the same as that of the naturally derived opioids, codeine and morphine. Of note, heroin is not on the slide, is two morphine molecules joined together in an acetyl group. There are known to be 4 types of opioid receptors, most of which are distributed in the nerve cells and in the gut and the brain. Opioid receptors are specialized. Sorry about that. Opioid receptors specialized proteins called G proteins, which are woven into the cell membrane of the neuron. Opioids act on neurons by binding to the receptor site of the receptor, which then activates the neuron to mediate a specific function. The natural ligands which bind to these receptors are our endogenous neurotransmitters known as endorphins, enkephalins, and dynorphins. It also happens that exogenous compounds have effects on these receptors, like opiates or opioids. Opiates are derived from the poppy plant, like morphine, codeine, and heroin, also known as natural. Opioids are synthetically manufactured, like oxycodone and methadone. Not all opioids have equal access to opioid receptors, as there are a finite number of opioid receptors in any individual. The one or many opioids present compete for the receptor site. When bound to the receptor site, some opioids have more effect than others. Some have maximal effect, also known as full agonists, for example, morphine, oxycodone, and methadone. The more you raise the dose, the more the effect. There is no ceiling, so overdose is more likely in this category of opioid. While others have partial effect or classified as partial agonists, the effect is partial. Buprenorphine is an example of a partial agonist. When naloxone is bound to the receptor, it displaces other opioids and exerts no effect on the neuron itself. Naloxone is classified as an antagonist. In an overdose intervention, the naloxone simply displaces any opioid presently bound to reverse the adverse effect. There are different types of opioid receptors which mediate different functions. For the purposes of this presentation, it would be important to note that all opioid receptor subtypes depress respiration. The overdose mechanism is largely attributed to the respiratory depressant effect. In an overdose, the respiratory rate reduces and breathing becomes more shallow and breathing stops. The starvation of oxygen to the brain leads to an unconscious state. I have seen many overdoses in these events, and the subject has little or no realization of the transition from the conscious state into the unconscious state. The subject has no power over intervening in their own overdose. The administration of naloxone is a standard procedure in emergency management of opioid overdose. It is fortunate, however, that naloxone binds to all receptor subtypes with high affinity, higher than most opioids. Of note, the other commonly available opioid antagonist on the market is naltrexone, which has a much lower affinity, therefore is not used in overdose reversal. Naloxone has a short half-life of 30 to 60 minutes and is shorter than most opioids, which have a half-life of 2 hours or longer. It is not uncommon in practice to see an individual lapse back into an overdose state due to the difference in half-life. Sometimes a second dose is needed after the naloxone is worn off and the opioid hasn't. In methadone and buprenorphine, for example, overdoses, since their half-life is 24 hours or longer, repeat doses or even infusions are needed. Buprenorphine also has a high affinity to naloxone. Not higher affinity than naloxone. It is not unusual also to need high doses of naloxone to overcome this type of overdose. As far as the type of administration of naloxone, IV is typically used in anesthesiology, where there is a readily available IV access line. This also lends itself to dose titration. The IM route is used most commonly in first responders and is effective. Intranasal or off-label, however, some services have been using this form both in take-home and in first responders, particularly in the US, and have been trialed and implemented by using a syringe and nasal aspirator based on the ease of administration for lay handlers and also a potential for lowering the risk of needle stick injuries. Cost is higher, however, due to the higher doses needed to reverse an overdose, and the shelf life is considerably shorter than the standard naloxone in glass ampoules. Subcutaneous can also be used, but if a needle is drawn up, then IM is preferred. There are many variables which contribute to the optimum dosing of naloxone. The dose could depend on whether the recipient is an opioid user or is naive. Also, the degree of tolerance of a specific individual is a factor. The type and the quantity of opioid taken, as well as the hemodynamic status of the individual, are some but not all of the possible factors which could have a bearing on the optimum dose to reverse the overdose. While the exact dose is seldomly known, in actual practice, from knowledge drawn from first responders in hospital emergency rooms, a dose of 0.4 milligrams given intramuscularly reverses the majority of overdoses. That said, there have been documented instances in which the dose needed to reverse binding has been as high as 20 times that. Specifically, examples in cases, as I described before, in buprenorphine. In an operating room, the anesthesiologist has the luxury of slowly titrating the dose to the desired effect. In emergent situations, this is simply not practical. While the standard dose of 0.4 works for the majority, there have been instances in which a second or additional doses would be necessary. On the other hand, one dose in some individuals could provoke an acute withdrawal syndrome and sometimes a violent reaction. Some of the signs of the syndrome are on the slide, and if too much is given, symptoms of acute withdrawal syndrome manifest. The symptoms of acute withdrawal syndrome are generally not life-threatening. However, they should be significantly alarming to the individual in a way that could potentially negatively impact the outcomes, which include self-discharge if they're in a hospital and also possible repeat drug exposure. As far as rare complications are concerned, in some post-operative patients, there have been some reports of hypotension or hypertension, as well as seizures, pulmonary edema, and arrhythmias. These are rare. The cases also reported occurred in patients who had pre-existing cardiovascular disorders or other drugs that may have contributed to the adverse cardiovascular events. In an emergency life-threatening situation, these complications should not preclude the administration of naloxone. As far as overdose risks are concerned, the potency of street drugs may vary from time to time and by a wide margin, so much so that the heroin user may think that they are using the usual dose when a higher potency heroin is used, and overdose can occur unintentionally. The change from an oral route to an injecting route of administration could increase the amount of drug delivered to the brain by 2 to 3-fold. This is certainly true of morphine, of which typically 1/3 is absorbed when taken orally, and when injected, the drug user is immediately introduced to 2-3 times the potency of the dose of morphine immediately and potentially causing overdose. Many deaths from opioid misuse occur with alcohol, other illicit drugs like cocaine and other stimulants, and also other sedative medications like benzodiazepines. Drug users who use their typical amount of opioid who decide to take other sedatives in addition increase their risk of overdose considerably. Decreased tolerance is also an issue from participants from being in detox, also attending a treatment facility, recent release from hospital or jail after a period of abstinence, well-documented periods of vulnerability. Drug users who go back to their habit using the same amount of drug after as few as 3 days of abstinence may find themselves overdosing due to the rapid loss of tolerance. Next, I would discuss a little bit on the regulations in Canada. In Canada, naloxone is regulated on Schedule F of the Food and Drug Regulations, which requires a prescription from a licensed physician or nurse practitioner. It is not a controlled substance, as most opioids are under a classification as a narcotic. When the drug was on patent, it was marketed as Narcan. The drug is now off patent. Sandoz is the only generic manufacturer in Canada, and the cost is approximately $12 per ampule, and there have been manufacturer shortages as well as rising costs. Naloxone is supplied in 0.4 and 1 milligram ampules, as you can see there on the slide, and also can be stored at room temperature, which is fortunate. However, it needs to be stored in a dark place in order to preserve the shelf life, which is generally around 2 years. Other drugs which also have naloxone in them include Targan and Suboxone.